Okay, good afternoon. Welcome everyone to the evolution of valve intervention session. We're going to talk about TAVR, mitral, and tricuspid as well. I'm Alan Yeung from Stanford University, and my co-moderator, Dr. Grube, is climbing up the mountain, he said, meaning that probably coming up the hotel, and he'll be a little late. The panelists are Dr. An, Dr. Hayashida, Dr. Khan, Dr. Ko, Dr. Lam, Dr. Lee, Dr. Lin, Dr. Park, Dr. Yamamoto, and Dr. Yin. So we have a great experienced group, multinational experience in this area. So the first session is going to talk about the great debate, TAVR for younger patients, meaning in their 60s. So instead of Dr. Grube start first, we're going to ask Dr. David Hildick-Smith of Sussex Cardiac Centre in the UK to talk about bioprosthetic valve durability, incidence, mechanisms, predictors, and management of valve degeneration.
Great. Thank you very much indeed for the introduction and for inviting me to this lovely conference. So bioprosthetic heart valve durability, it's a very topical issue at the moment, and I think it's worth starting off by stating quite clearly that all bioprosthetic valves will fail eventually if the patient lives long enough. There is no magic formula, there are no magic valves which are resistant to this phenomenon. We've got ourselves slightly into a mess with our definitions. I think structural valve deterioration and bioprosthetic valve failure, they're quite complex definitions. You can have bioprosthetic failure with severe valve degeneration in an overlapping formation in this Venn diagram with moderate valve degeneration on the left. What we really want to know, of course, is when a valve has deteriorated badly enough to warrant re-intervention. Actually, the definitions have been slightly adjusted to add an increased mean gradient of 10 millimeter mercury from the time after intervention. So as you can see, depending on the definition, this is just taken from the Notion study, for example, depending on which definition you use, in the blue we have surgical prostheses, in the red we have the transcatheter prostheses, you'll get quite a different rate of bioprosthetic valve deterioration / failure, ranging from 28% over on this side down to 8% here in the same cohort. So somewhere along the line, I think we probably need to clarify these definitions a bit. Anyway, all valves are different, and that goes for transcatheter valves, and surgical valves are not, as a group, necessarily better than the other group. Each individual valve is different, and we've seen that, particularly here, for example, last year with the pretty terrible trifecta valve, which, as you can see, is doing very badly. We have a lot of experience of that in the United Kingdom, patients coming back for TAVI in a trifecta valve, which has the added complexity, of course, that you can't crack the valve ring. That's in comparison, for example, here with the Intuity valve, which you see from this graph is progressing very well out to at least 8 years. Having put the boot in slightly on surgery, it's probably important to redress the balance by saying, well, yes, that's all well and good, but if you put a valve in like this, in a bicuspid, this patient is unlikely to get very good durability out of that valve either. So what are the factors that affect durability? Well, of course, there are many, but I'm going to focus on just a few to illustrate some important points. So firstly, the size of the implanted valve is very important. Here are data from partner 2, in fact, looking at the 23 millimeter and 26 millimeter valves, and you can see that in the blue, the 23 millimeter has a substantially higher mean gradient at 5 years than does the comparable 26 millimeter durability. And of course, mean gradients will likely develop into high rates of problems, and as was seen with this particular study, it did indeed generate more problems. The patients with the smaller caliber sapien valve actually had measurably higher mortality out at 5 years. So patient prosthesis mismatch. This is another interesting and apposite topic, not disconnected to the previous one. This is from the core valve high risk study, combining TAVR and surgical prostheses in the lowest annular sizes. You could see that the patients with severe patient prosthesis mismatch, even at only 2 years, had a much higher, measurably higher all-cause mortality. So patient prosthesis mismatch is really important. In the low-risk core valve study, now out to 3 years, seeing very good valve areas in the evolute cohort, pretty good valve areas in the surgical cohort, still a preference for the transcatheter valve in terms of quality of low gradients across the valve and effective orifice area. We've also seen this in the UK data out to, well, some of these patients are out to 12 years, but the average was 8.5 years. Here we have the balloon expandable valve with a mean gradient of about 17 millimeters mercury. Here we have the long-term follow-up on the self-expanding valves, which were largely core valve, of course, out to, well, probably exclusively core valve, actually, out to 8 years, with a lower gradient, lower mean gradient. So the type of valve appears to be important. Here, when we look at the hazard ratios, comparing the balloon expandable valve with the self-expanding valve, the durability of the self-expanding out on the red line here is excellent. The durability of the balloon expanding valve shows some attenuation from perhaps 6 or 7 years onwards, and we'll continue to track this. What about the method of implantation? This is obviously something which we all love to sort of argue about. Very interestingly, the Notion study, which had sort of first lead, if you like, in this territory, out at 8 years, is very similar between the two groups, despite the fact that, of course, the implantation characteristics are very different. When you look at the valve performance in these two groups, you can see that the mean gradient is becoming significantly higher in the surgical valves than it is in the transcatheter valves. And we see the structural deterioration much higher in the surgical valves. So perhaps the fact that the mortality is remaining the same is balanced by other factors, possibly the slightly increased regurgitation that is seen with the transcatheter valves. And in a large meta-analysis, I'm not usually much of a fan of meta-analyses, but in a large meta-analysis, structural valve deterioration was seen to be worse with the balloon expandable than the self-expanding valves. This is perhaps a little historical, and more up-to-date data will find its way to us soon. So in summary, really, I think the things we thought we knew turn out to be true after all, and these are that the surgical sewing ring occupies space that could be used for a valve, and that is bad for the valve area, it's bad for the valve gradient, and it's bad for the valve longevity. Patient prosthesis mismatch, which is a rather fancy way of saying you put in too small a valve, is commoner with the surgical valves, results in a higher valve gradient, smaller valve areas, and reduced valve longevity, also reduced patient survival. And so the self-expanding supraannular valves actually offer better valve area, better valve gradients, better valve longevity. And the larger the valve that you put in, the better result you get in terms of the same parameters. So to summarize, bigger is better, transcatheter is better, and self-expanding is better. Thank you.
Thank you, David. We'll come back to discussion later on. So the next topic is to how to treat the failed bioprosthetic SAVR or TAVR valve by Dr. Kaneko from Washington University.
Thank you so much for the introduction. So my theme is how to treat the failed bioprosthesis, both SAVR and TAVR valves. These are my disclosures. So how do the surgical valves fail? I think we can learn sort of the mode, how these bioprostheses fail. And this is looking at the adult cardiac surgery database from the STS from 2011 to 2013. In the mode of failure on patients who underwent repeat SAVR, 87% was structural valve deterioration and 13% was endocarditis. You would think that the TAVR population would be somewhat similar, although we don't know completely yet. And as Dr. Smith's talk, all bioprostheses fail, but we know that when you have younger patients, they do fail much, much faster compared to the elderly. And the growth of TAVR into the younger patient population, you can see that the TAVR growth has surpassed the number of total surgical aortic valve replacements in orange back in 2018. And also the median age, I want you to look at the blue line, that is in the low-risk population, has steadily come down now into the mid-70s. So the younger the patient gets and the lower risk the patient gets, we think that we might see an increase in needing the second procedure. So what is the outcome of repeat surgical aortic valve replacements? These are not an easy operation. They do have some technical difficulty. And we found that despite the predicted risk of 5.4%, the operative mortality was 4.7%. In this day and age, operative mortality of 4.7% is considered relatively high. So these are not an easy operation. When you compare these repeat surgical aortic valve replacements to valve-in-valve TAVRs, you can see that the short-term mortalities are much, much better with valve-in-valve TAVR. And these are through the National Readmission Database and multiple readjustments. They did not see any difference. And the 30-day mortality and 30-day morbidity was much, much better with valve-in-valve TAVR. However, this was a French study that looked at valve-in-valve TAVR versus repeat SAVR. And after 2 years, the line crossed, meaning that the valve-in-valve TAVR population did worse. And maybe this was more of a selection bias between the two groups. However, one of the hypotheses is that these valve-in-valve TAVR patients have what we call pinwheeling, and they're not fully expanded. And when you have pinwheeling, there is some concern that this leads to valve thrombosis. And we had some conversations about the leaflet thrombosis in the previous sessions, but at the moment, a lot of these leaflet thrombosis, both P3 and Evolute, HALT did not result in hemodynamic changes. So we really don't know at this point, but the biggest question is, does leaflet thrombosis lead to structural valve deterioration? And when you take out a valve like this, you know that they have some consequence down the road. So when you have a failed TAVR, I think this is sort of the focus of the talk today, if they fail through structural valve deterioration, there's only two ways to treat this. You either put a TAVR valve inside or you take it out. And I'm not going to repeat the notion 8-year outcome, but these trials have shown that the structural valve deterioration rate may be higher in the surgical population. So I'm going to first start with a TAVI explant, and these will have a significant impact as the younger implanting age sort of continues to diminish. So this was one of the studies that we presented, looking at TAVR explants. And the TAVR explant age was relatively young. They were in the mid-70s. I'm going to skip some of these. The most important part was that the 30-day mortality was 13% in this Medicare series. And there's been a couple other series that looked at TAVR explant, and their mortality has consistently been between 10 to 20%. There was 2 articles that came out in JACC Interventions this week. Both showed similar results. The concern about TAVR explant, these are some of the videos. The left side is my video taking out a sapien valve. The right one is taking out the core valve. The dissection of the stent frame from the aorta may be sometimes very difficult due to the attachment, and you have to deform some of the frames. And then the key point is to getting into the plane between the native valve and the TAVR valve. Once you can do that, you can actually take it out relatively easy. But the most important thing is that oftentimes when these patients present, they have severe MR, severe TR, some LV dysfunction. They come very delayed, meaning that they bounce around some of the physicians, and by the time they present to us, they're often too sick. And that's part of the reason why these surgeries have high mortalities. Also, the TAVR explant is done in only small number of surgeons. This is relatively old data from 2018, looking at STS database, but the median case per surgeon was 1 in the US, and median case per center was also 1 in the United States. So the surgeons, as of now, don't really have the experience to do this operation, and we're trying to teach this rapidly to understand the technique. So how is repeat TAVR? Putting a TAVR inside of the old one. The first series that came out from Vancouver, Landis, reported incidence of only 0.2%, but 30-day mortality of 1.4%. So the mortality was extremely low when the repeat TAVR was performed. And when they compare this to TAV and SAV, the outcomes were very, very similar, meaning they had similar mortality or morbidity compared to TAV and SAV. So the issues with TAV and TAV, one of the major issues is what we call sinus sequestration. So when you implant a second valve inside of the index TAVR valve, the old leaflet of the TAVR valve expands and creates a cylinder, and when that touches a sinotubular junction, it creates an obstruction of flow into that sinus. And the risk of this sinus sequestration seems to be dependent on the type of valve that's implanted. And this is an exploratory study done from the European group, and they calculated the risk based on the risk plane of how these valves are implanted. And based on different types of valves, the risk of sinus sequestration became higher. But the point is that even in the lowest risk group, there was about 20% of patients that had sinus sequestration. And another new findings that people are finding is this phenomenon called leaflet overhang. When you implant a sapien valve inside of a core valve, when you implant it very low, you see this leaflet overhanging all the way to the left on top of the new TAVR valve that's being implanted. The significance of this is still unknown. I think the most recent paper has shown that putting a second valve in node 5 has been the best outcome, and we're going to learn more and more about this. Putting a sapien valve inside of the core valve has always been the discussion of this TAV and TAV. We did compare the two outcomes between TAV and TAVR explant. The repeat TAVR, the TAV and TAV, seems to have a lower 30-day outcome. But when you look at the long-term outcomes, the TAVR explants do better. I think there's some selection bias still left in this group, but we're going to learn more and more about this. And when these patients come back with failed TAVR valve, everyone wants to put another TAVR valve in. Nobody would want to operate on them. So we're going to need to learn about some of the things, but can we do something to change how we implant the index TAVR? So if you're putting it on a 91-year-old, you can implant the sapien valve really high as you can. But if you're implanting on a 66-year-old, maybe you want to implant it more close to 75-25 and allow that STJ to not touch from the stent frame and allow the second TAVR much, much easier without the concerns of sinus sequestration. The last thing I do want to talk about is the simulation. So DASI simulations nowadays, they can actually implant these first valve and the second valve in a different height, and that will tell you whether the sinus sequestration will occur. So if the first valve is implanted low, then the second valve might be able to be implanted a little higher to prevent leaflet overhang. The other thing that's being studied right now is the leaflet modification technology. This is a shortcut technique, which is replicating the basilica technique, and this may allow us to do the second TAVR procedure. There's some leaflet excision technique that's being explored as well, so I think we're going to see more and more about this field in the future. So thank you very much.
Yeah. Thank you. Dr. Grube is here, and he's going to deliver the talk, How to Prevent TAVR Complications with New TAVR Devices. Eberhard?
Yeah, thank you very much, and I apologize, everything was a little late. Now, the topic here is how can new TAVR devices reduce complications. Those are my financial disclosures. The ideal transcatheter aortic valve is very well defined, should be durable, low profile for transfemoral delivery, low complication rates, simple, predictable deployment, minimal interference with surrounding structures, and of course, optimal valve performance. The next generation THV design with a focus on lifetime management of aortic stenosis have to be considered, and we have to prioritize the procedure in the future. We have to look for optimizing the index procedure, extend the valve longevity, maintain coronary access, and plan for THV in THV procedures. New tissue processes and novel materials are actively being researched, and this research may address actually shortcomings of current bioprosthetic valves. Clinical trial and real-world data show that the new TAVR systems are producing excellent clinical outcomes. They are improving and addressing further conduction, PVL, coronary, and peripheral access issues, so-called lifetime managements for younger patients. By improving deployment accuracy and ease of use, new repositionable systems, continued advancements of the devices, advanced steering, torqueability, depth control, low-profile materials, and obviously we'd like to ensure durability by continued trial follow-up and engineering and bench testing with tissue engineering, FEA modeling, and animal testing. What were the current challenges for TAVR devices? The so-called Big Five. Some of them, or most of them, were at that time associated with mortality. And here the STS National Database of the United States, we've done quite well with the devices. Mortality, as we all know, came really down. Bleeding, major bleedings, disabling bleeding came down. In-hospital pacemaker rates came down. And of course, TAVR stroke rate came down, although TAVR, the stroke rates are hovering between 1.5 and 3, depending on how closely they're followed up. So we have so many TAVR choices. How do we optimize outcomes with each, and which device is best for which patient? So let's distill the essentials. No matter the device, there are two keys to optimizing TAVR outcomes and reducing complications: patient evaluation and sizing, and correct implant technique. Each device has its own nuances for sizing, and for implant technique, you must understand the specifics for the device that you are choosing. If you look at a patient like that with a very complex anatomy, calcification, tortuosity, if you have a patient with the above risk factors, then the device should be designed to minimize PVL, vascular complications, and stroke. Beginning with new technologies, the Evolut FX system, the design features, the nose cone has been redesigned, more flexible capsule, single spine shaft, optimized stability layer, and 3 inflow markers for secure and better positioning. Then improving bioprosthetic durability profiles, new technologies. It's all about the leaflets and the material science innovation. Edwards X4 Resilia tissue valve, addressing anti-calcification treatments, and Terra's Dura transcatheter valve, single-piece 3D shape, also with anti-calcification treatment, and the Foldex Trier heart valve, which has polymer leaflets and completely robotic manufacturing. Rebooting or increasing momentum, the Jenner trilogy valve, the J valve, and the Venus valve. The Venus Vita valve and the Venus Power X valves are balloon expandable and self-expanding additions of the Venus portfolio. They're addressing anti-calcification treated with dry tissue and addressing the PVLs by embedded PU foam for both. Transfemoral J-valve from China, the transapical device has been approved by the Chinese FDA in 2017, now is gaining momentum in the United States with the compassionate use cases, so they're fairly aggressive in the United States. In Europe, the Jenner trilogy valve has been approved for aortic stenosis and aortic regurgitation, and there are interesting features to this particular device. There are locators that you can see here in this little animation, seating in the sinuses, so there's anatomically correct positioning, alignment by design, control implant depth by the locators, eliminating PVL by clipping the locators to the native cusps and then secure anchoring. And then the large cell allows for coronary access. This is a case example that we did a few weeks ago, eliminating really in the middle picture, you can see the locator sitting in the sinuses, eliminating aortic regurgitation completely. This is an interesting study, the multi-center summary, the German registry for both aortic stenosis and aortic regurgitation. Most important, you can see on the right side, eliminating aortic regurgitation with excellent outcomes, technical and device success. If you look at the lower part, new pacemaker rates, interesting finding. In the cohort of aortic stenosis, you have low one-digit pacemaker numbers. In this cohort, 2.9%, and as we move in Germany to next 120 patients, we see basically the same numbers. Those numbers are increasing with aortic regurgitation, and that goes along with the US finding between 15 and 18%. An interesting other valve is the ultra-low profile TAVR system, the Geminus valve from Valve Medical in Israel. Very, very low profile, comparing on the left side the Geminus OD, outer diameter, that was what goes into the patient, comparing it to Evolut, Actuate, and Sapien. This is obviously a modular approach. As you can see here, it's docking the two modules in the ascending aorta. The first successful case has been done in Dante Pasanese in 2016 by Dr. Abizad, myself, and Dr. Leon, and it was quite successful. The company redesigned the valve. We'll do within the next 4 weeks, in the next generation in Israel. So some final thoughts. The risk for each complication will vary on a case-by-case basis, and all available information should be weighed to come up with an individualized plan for each patient. The key to mitigating most complications is proper valve size selection and proper placement. Recapture technology should be exploited whenever necessary to ensure the patient leaves the room with the valve in the right location. However, caveats to consider, brief summary, there is no single perfect TAVR system, strong subjective opinions regarding features, significant operator experience necessary to formulate thoughtful impressions, and future TAVR systems should be expected to treat all patients with aortic stenosis, especially patients with lower risk and bicuspids. What's hot? The industry leaders continue to iterate and innovate. Rapid emergence of other TAVR systems, new TAVR systems coming in from China. They're entering the clinical marketplace, Venus A and JVIV as an example, but others you know. And TAVR newcomers are developing novel device designs, dry leaflet technology, PVL prevention, and ultra-low profiles. Tissue engineering concepts are quickly evolving and may spark a future round of improved valve leaflet designs. New techniques for lifetime management and AV remodeling are increasingly being used. With that, I will finish, and thank you very much.
Thank you, Eberhard. So now we're going to summarize this session with two perspectives. First is from the interventionalist perspective, and Dr. Palmerini is going to give thank you. From Italy, is going to talk about from the interventionalist perspective.
Thank you very much. So whether TAVI can be expanded to a population of younger patients is now a matter of speculation, because we don't have evidence-based data that can support this recommendation. These are the only data we have. Partner 3, in which TAVI is indeed superior to surgery, but unfortunately we have just 2 years follow-up. And then we have Evolut low risk, we have data 3 years. Again, TAVI is superior to surgery, but we have just 3 years follow-up. So in this journey, in which we are going to speculate about the possible lifetime journey of these patients, we have 3 variables. We have a target variable, which is life expectancy, and 2 independent variables, which are valve durability and the possibility, and which kind of reintervention are we going to make. So let's define the first variable, life expectancy. In South Korea, life expectancy is around 85 years old, which is similar to the majority of countries in the Western world. So if we have a patient who is 60 years old, we have a life expectancy of at least 25 years. And therefore, we will have a two-stage journey if the valve durability is at least 15 years, with 4 possible combinations. I don't think there is a strategy that would fit all patients, but probably this strategy would depend on the aortic root anatomy, the risk of coronary occlusion, the possibility of engaging coronary arteries and the risk of patient prosthesis mismatch. So let's start analyzing the first combination, which is surgery and then surgery, just not because I think this is really on the table, but because this is going to be a benchmark against which each strategy involving TAVI should be compared. Now, with contemporary operative mortality, the contemporary operative mortality of reduced surgery is around between 4 and 9%. But we must be very careful when interpreting this data, because if we look at these patients here in this study, mean age was 66 years, in this study 51 years, in this study 58 years, in this study 59 years. So when we talk about redo in TAVI patient, we have a much older population. So first surgery, then TAVI, probably this is going to be a strategy which can be appropriate for patients with small aortic root and shallow sinuses with low takeoff of the coronary arteries. And this is because the armamentarium surgery seems to be appropriate for this kind of patient, because there are new valve with Resilia technology, more importantly with sewing ring that can be expanded with the Vista technology that can accommodate TAVI. Then we have technique that can enlarge the aortic root, and we know that valve-in-valve is an established procedure which, with acceptable safety and efficacy. This is indeed a meta-analysis with 12 studies, more than 60,000 patients, and you see that TAVI in TAVI is associated with lower 30 days mortality than reduced surgery, and a trend toward lower mortality at 1 year, but of course this is a meta-analysis of observational studies, and therefore there are many biases. So TAVI, probably this is a strategy that would apply to patients with large aortic roots, wide stenosis, and high takeoff of coronary ostia. And this is because that when you do TAVI in TAVI, you create a neoskirt. In fact, by tilting up the leaflet of the first TAVI, you create a cover stand, like a cover stand. And this is a problem for coronary ostia, because this would bring a higher risk of coronary obstruction with 2 main mechanisms, deficient sinuses and sinus sequestration, and coronary incannulation, which is going to be more difficult when the coronary lies below the neoskirt. Of course, if there is a new technology, this is the shortcut, which is going to cut the leaflet, and probably if this technology would be successful, this strategy could be implemented in a higher proportion of patients. There is also another problem, which is linked to the strategy that you use, such that if you use first an evolute valve, if you do a low implant with a Sapien, you are going to have the problem of overhanging leaflet, whereas if you do a high implant, you are going to have the cover stand effect. And these are all considerations that you have to take in mind. The other problem in young patient is the possibility to engage coronary arteries. This is a study, a prospective study, so almost 1,000 patients. Mean age of this patient was in the 80s, and you see that 10% of the patient population needed to undergo coronary angiography because of an acute coronary syndrome. And this number is going to be higher in a younger population. So behind the traditional variables associated with the possibility to incannulate the coronary, there are specific variables which has the functional neoskirt height, the height and dimension of the lowest accessible cell, and I'll show you what it is in a moment, and the cell alignment between the 2 transcatheter valves. So this is the lowest accessible cell, which is the first cell above the neoskirt. This is the only point entry that you have when you have to engage the coronary arteries. So functional neoskirt, of course, depend on the depth of first and second valve implantation, such that you have to sum the neoskirt with the skirt of the second valve, but it also depends on the sequence of valve that you use, such that if you use a sapien valve as a first implant, you are going to have shorter neoskirt height respect to evolute, irrespective of what you put after. And also, if you put an accurate in a sapien, you are going to have a bigger dimension of the lowest accessible cell, and if you put an evolute in an evolute, you are going to have the smallest cell dimension, especially if there is no alignment. So we have data about this kind of strategy, TAVI in TAVI. This is an international prospective studies with 212 TAVR. Mortality was 1.4%, risk of coronary obstruction 0.7%. This is a larger studies in a Medicare setting. Rates of mortality was higher, 6%, but importantly, repeat TAVI was associated with lower mortality than TAVR explant, even though a long-term follow-up there was a catch-up. But again, this is not a randomized study, this is an observational studies. And finally, if the valves are going to last less than 15 years, you are going to have a journey with 3 implants and 8 possibilities. So to me, this would be the most appealing strategy because it's the one that can minimize the invasiveness and mitigate the risk of patient prosthesis mismatch and the risk of coronary obstruction. But we have already seen the problems of this strategy. Mortality may be, like Dr. Kaneko showed, as high as 30%. It is not clear at this stage, but probably it is a combination of patient frailty and clinical risk factor. These studies have repeated TAVR in patients in their 70s, whereas reduced surgery was done in patients in their 50s. May depends on a specific factor associated to the procedure itself, like the tissue that grows inside the valve, the complexity of the surgery, and as Dr. Kaneko said, probably also the experience of surgeon. So in conclusion, a significant proportion of younger patients are being offered TAVI nowadays, although several issues are still unsettled. Iteration of devices with better commissure alignment, a leaflet modification devices may reduce TAVR feasible for a significant proportion of patients. Valve selection will likely depend on patient life expectancy and preference in patient anatomy in terms of aortic root dimension, risk of coronary obstruction, and possibility to engage coronary arteries. Thank you.
Let me finish this then. So Dr. Kaneko, could you come back up and talk about the surgeon's perspective? And after this, we'll have a panel discussion.
Thank you. I don't see a lot of surgeons in the room, so I feel like the Japanese national soccer team play in Korea, but I'm going to do my best. So you can see that the SAVR numbers really have plummeted, and the orange number is TAVR in the United States have really increased in its number. And as I mentioned in the previous talk, the median age is coming down. So right now, this is how SAVR feels like, being choked by Darth Vader. But there are a couple of things that we sort of have to keep in mind. And one of the things is that there were a lot of exclusions from these randomized control studies that were really basis of the supporting the TAVR over SAVR. So one of the things is bicuspid aortic valve. Bicuspid aortic valve, when you compare it to a tri-leaflet valve, the TAVR outcomes have been relatively good. This was shown in multiple papers, not just this one. However, on the other hand, it really matters based on the anatomy. If you have calcified raphe or excess leaflet calcification, these patients did not do well after TAVR. So these patients may not be a great candidate for SAVR. This is something that we looked at the STS database. Even after risk adjustment with SAVR, they do better than the tri-leaflet valves. So in these patients, maybe they should get surgical aortic valve replacement rather than SAVR. Severe MR was another exclusion for these clinical trials. And this was a series from Europe looking at severe MR patients or moderate or severe MR patients after TAVR. And they found that these were some of the risk factors. So if they have baseline severe MR, they don't get better, meaning that maybe these patients should undergo surgery and fix both or consider MitraClip However, that efficacy may be unpredictable. The other thing is one of the new concepts that came out from Minneapolis. When the TAVR valves expand, some of these valves are expanded asymmetrically. If these valves are expanded asymmetrically, it was very interesting that they saw more halt in these patients. And you would easily predict that these patients with halt can have early structural valve deterioration. So maybe these patients that have asymmetrical expansion may do bad, especially in younger patients who tend to have more bicuspid aortic valve. We have spoken a lot about patient prosthesis mismatch today. The patient prosthesis mismatch has been shown both on surgery and TAVR to be a risk factor. And there are aortic root enlargement techniques that we can do. So aortic root enlargement is a very easy concept. You take a ring, you cut it, and then you put a patch to make it bigger. That's how the aortic root enlargement works. And the aortic root enlargement outcomes have been criticized because there is some risk added to the procedure itself. Just to describe, the operative mortality did increase after the adjustment about 50%. So there is an upfront risk that you take, but the survival benefit sort of came up after 3 years. So you take the risk up front, and then there's a survival benefit in a long term in these patients undergoing surgical root enlargement. This was one of my own patients that had a very, very close valve after the close coronary distance, VTC, after the initial valve. And I ended up performing a root enlargement in this patient. I'm going to skip this video a little bit so that you can see. This is the annulus where I'm sort of enlarging both directions. This is the Y technique that Bo-Yang has proposed recently. And after putting the patch in, we increased a 21 millimeter valve to 25 millimeter after implantation. So we were able to implant a much, much larger valve afterwards. And this is the interesting part. So after putting the larger valve in, we saw that the VTC distance enlarged, although the coronary height decreased. So, by doing the root enlargement, you can actually increase that valve to coronary distance and, allow potential future valve-in-valve by doing this. The fourth point is the choice of mechanical prosthesis. So mechanical valve really has a bad rep because nobody really wants to be on anticoagulation. But the best paper that's out there from New England Journal of Medicine back in 2017, looking at California state database, showed that the mechanical valve had lower mortality than bioprosthetic valve in age between 45 to 54. And when they broke it down, the hinge point was 53 years old. So if you were younger than 53, the mechanical valve patients lived longer. So that's one of the basis of potentially putting mechanical valves into younger patients. And also the fifth point is concerns about TAVR explant. I did talk about this on my previous talk, but they do have high mortality. And if you implant a TAVR the first time, and for whatever reason, if they're not qualified for repeat TAVR, you have to undergo that high-risk procedure the second time. And as I mentioned, about over 25% of patients do not qualify for TAV and TAV at this point. Of course, this may change in the future. The sixth point is the Ross procedure, which is regaining some of attention again. It made it to the 2020 valve guidelines. There's a class 2B recommendation in patients under 50 years old. For those of you who may not have heard Ross procedure is when you take out the pulmonic valve and then implant it in the aortic position. We put a homograft on the pulmonic position. And this really has gained attention because of this study and some of the other studies. This is looking at the New York State database. Ismail El-Hamamsi, who's a surgeon over at Mount Sinai, sort of reselected this procedure. But what this study really shows is that the Ross procedure is the only procedure that restored the general population life expectancy. So even if you got bioprosthesis or a mechanical valve, their mortality decreased compared to the general population, and the Ross procedure was the only procedure that was able to keep it. This was one of my own Ross procedure that I did. He was 51, bicuspid aortic valve, and after doing some research, he wanted to get the Ross procedure. This is putting the suture in in the position, and this is after implantation of the pulmonic valve. You can see that the valve is intact. And one amazing thing about this procedure is that the hemodynamics are excellent. Usually the gradients are less than 5. So that's one of the benefits of this procedure. So in my opinion, SAVR will stay in the future. Randomized control study excluded patients in the low risk should be considered for surgical aortic valve replacement. Bicuspid aortic valve, severe MR, TR, complex coronary disease, we can go on and on about this conversation. And I do believe that this asymmetric expansion will be a problem. We definitely see more halt in the TAVR population, and we're gonna dissect and we're gonna learn more and more about this. Aortic root enlargement, SAVR in patient prosthesis mismatch patients, actually we can make the valve bigger and allow them to be a candidate for future valve-in-valve. So rather than putting a small TAVR valve in, it may be better to put a bigger SAVR valve in with the potential to do valve-in-valve in the future. And TAVR explant is a high-risk procedure, and you don't want that to happen, although implanting a TAVR in younger population may have that possibility. And Ross and mechanical valve for younger patients may be an option. I think these are good options for younger patients, and you can only do these through surgery. So I think surgery is going to make a comeback. So thank you very much.
Dr. Kaneko, why don't you stay up here since you are one of the few surgeons here, so we can have you help us discuss some of these issues. So any questions for Dr. Kaneko first?
Yeah, I think that was a beautiful summary. And I think we have to be really careful. You know, the numbers, and you pointed that out very adequately. You know, there is definitely a creep of use in the United States and in Europe based on our successes, but we really don't have any data. And I think we should really consider an age cutoff at 65. You know, if you're a little bit more conservative, you can say 70, but you know, below 65, things are getting complicated because we really don't have any data. And my feeling is that the tendency is, you know, that we are, given the success that we have in the older group, that we're moving down, which I would like to call creep, and whether that's justified or not, I question that. Would you comment on that?
Yeah, great comment, Eberhard. Yes, part of the problem is that not just us, the patients want it. Patients tend to come into clinic and say that I want TAVR. I never want my chest cracked open. And that happens very, very frequently. And if we say that you're going to get SAVR, this patient might go to another institution and try to get TAVR, right? So they might do the doctor shopping. And that's sometimes what makes it hard. And you know, the less educated people may go for the less invasive procedure. And that's where we have to work as a heart team and, you know, spend some time to explain to the patients. I think we really have to educate the patients as well. I think that's the other factor.
Just one quick one, mechanical valves. You know, there's always this question of mechanical valves. I think if I was 50, sometimes I wish I was, but since I'm not, and I don't have a choice between bioprosthetic and mechanicals, I think the problem with mechanical valves, even though the number of complications has been down with mechanical valves, I think the issue really is if something happens, then it's an emergency, and you will not have that with bioprosthetic valves. In other words, if mechanical valves fail, then usually it's something that you have to react very quickly on.
Yeah.
Whereas bioprosthetic valves, you have some time to resolve the questions.
Mm-hmm. I completely agree. And there was one significant study that came out that I didn't show because I was pro for surgery, but PROACT 10A trial, which was a very important trial for a mechanical valve. They randomized patients between Coumadin and DOAC. And that got early termination because the DOAC arm had more complications. And I think that was a very significant study because if that study was positive or if it was non-inferior, I think people would be more willing to take DOAC rather than warfarin. To your point, yes, acute thrombosis and acute leaflet thrombosis on the mechanical valve could really be a problem. So yes, for that reason, I think it's continue to be unpopular, but I think we have to keep it as one of the options for younger patients.
Dr. Yin.
Yeah, I have a question. Do you think, as a surgeon, consider the surgical resection of the leaflet only of the transcatheter valve and put the second one?
Right,
Is that a good idea to avoid coronary issue and overhang and etc.?
I think there's some use to that technique. I don't think it's for everyone. If you think about patient-prosthesis mismatch, it is that cuff and the extra tissue that creates a problem, and you're leaving that in. So you are creating further patient-prosthesis mismatch. So if you can avoid it, I would advocate more on the explant of the whole TAVR valve itself. But sometimes, accessing the valve itself may be very hard, could be very stuck, and create more complex surgery. And for those cases, it may be applicable, but not all cases.
Question?
I have a question about the aortic root enlargement, because in Asia, I know this quite often to have a post-SAVR PPM because the Asian people is more small stature.
Right.
But I have seldom to see the Asian surgeon to do the aortic root enlargement. Is there any more add-on risk to add this kind of a procedure during SAVR in Asian people?
Well, full disclosure, most of my patients that I operate on are Americans, so I don't know much about operating on Japanese patients, I'll be very honest. But I think the patient-prosthesis mismatch is based on the BSA, and the BSA is very small in Japan, and I think that has something to do with it. The concern there is the future valve-in-valve, TAV and SAV. If you're implanting on a small valve, I think that's a concern. But in terms of the SAVR patient-prosthesis mismatch, it may actually be very low because of the small BSA. Kentaro, do you have anything to add on that?
So actually, sometimes we have the cases with very small BSA, which leads to the lower incidence of the prosthesis patient mismatch. It doesn't matter that much in our Japanese cohort.
Also, my comment is same. Is Euihong technique is now frequently doing the cardiac surgery in our Assam Medical Center. Is there any concern future valve-in-valve procedure or future further intervention? Is Euihong technique is a safe procedure? Or?
You mean after the aortic root enlargement?
Yeah.
Yes. There's going to be a publication on this, but if you do a valve-in-valve, as I showed in that one case, the coronary height will become lower, but the VTC will become larger if you do it right. And that technically should allow you, and we can also eliminate the waste of the STJ. We can actually sort of make it flat so that you're not going to have that sinus sequestration. So, yes.
Michael has a question.
Yeah, quick question, Kaneko. Some of the surgeons open the chest and then put in a self-expanding device, the aortic device.
Yes, the sutureless valve.
Why would they do it? Why not transcatheterly? Why would they open the chest and then put in a self-expanding device?
Well, I'm completely with you on that. Okay. I'm not a strong advocate for that procedure because I sort of think that you're combining the worst part of both TAVR and SAVR. But to people's points, it does decrease the cross-clamp time. And for complex endocarditis, some people advocate doing that because you can minimize some of the reconstruction. So there are some strong users in Europe, but I think in the United States, the usage has diminished dramatically.
A couple quick things. So why is Ross making comeback? It's just that, how surgeons are, they sort of sometimes take old stuff and come back and say, well, this is new.
Right.
Why is it better now? And why does the trifecta fail?
So those are two completely separate questions. So I'll try to answer one by one.
Try to get you on side. Yeah.
Yes. So the Ross procedure, it really made a comeback because of some of the revisions in the techniques that we're using. So what we found was that the way that they fail is that the STJ and the pulmonic autograft dilates, and then they get pulmonary insufficiency. So right now, the technique is modified, and we cut right at the STJ. So we actually secure that with another graft. Some people actually put it inside of the graft, but we secure it at the STJ so that the STJ doesn't expand, which we believe that will diminish some of the aortic insufficiency. Trifecta failed because the leaflet is on the outside. Very obvious. Mitral flow failed, trifecta failed. But I do remember when that valve first came out, I was still a trainee, and it was seen as sort of like this new panacea. I mean, it was believed to be the solution to everything. And we have to understand that we're going to see a lot of this in the future with innovations.
I remember that too, by the way. And mitral flow, surgeons thought that's a bigger EOA, and that's why they could avoid the root enlargement by using these kind of valves, and that was a bad decision actually.
So thank you so much. I hope you don't feel like, Darth Vader attacked by the Jedi, so type of thing. So thank you.
I think this is the absolutely unfair battle. One cardiac surgeon, 10 interventional cardiologists.
Right, but he'd make a draw, so it's pretty good. But I think the question, maybe to conclude this section, is that you have a 65-year-old with aortic stenosis coming to see you. You have to individualize that patient because there's a lot of different factors that in it. Commonly, they probably has bicuspid of some nature. And commonly, there might be some aortic root dilatation, maybe not enough to have surgery. So there's a lot of factors that would make you choose either SAVR first or TAVR first. But so I don't think you can, across all patients should be one first, because sometimes it could be having TAVR first, and then next time the root is bigger now, you do a total root replacement and taking the TAVR out. So I think my learning from this is that you have to individualize for that patient, because a 65-year-old is not, similar to an 85-year-old aortic stenosis, and therefore, rather than making sort of some, blanket statement that you should do this first and that first, I think that patient, given his anatomy, you decide what is best for that patient. So that's kind of what I learned from this. Eberhard, turn it over to you next.
No, I just wanted to add to that, Alan, there are many things that we claim that are important and that play a role in valve-in-valve situations. And, I don't know whether you guys agree to it, that PPM is much talked about. But I think as far as longevity and mortality is concerned, only severe PPM had an impact. Light and moderate PPM, even though those numbers are important to talk about and keep in mind, but I don't think they convey into any mortality changes. Severe PPM we should definitely try to avoid, but I think everything lower than that is maybe more numbers than reality. So what am I supposed to do now? Okay, so master's case presentation of changing concept. It's David Cohen.
Yes.
David.
So, and now for something completely different, we're going to switch valves and talk about the mitral valve. I really didn't understand my topic, so I'm going to just talk about what's next in the mitral valve and sort of where the guidelines fit in, because that was the best I could figure out from the topic. These are my disclosures. So I'm going to talk about three things. I'm going to talk about the guidelines that we have now for mitral valve transcatheter interventions. I'm going to talk about expanding indications for edge-to-edge repair and what's going to drive that. And then I want to talk a little bit about transcatheter mitral valve replacement, which is not yet a reality in many parts of the world, like the United States. So in terms of the guidelines, where do things stand? It's actually pretty interesting. This kind of gave me a chance to read the guidelines. And this is a summary of the guidelines for primary mitral regurgitation. And you can see transcatheter edge-to-edge repair, MitraClip, and Pascal device are down here in this lower left-hand quadrant, one little spot with a 2A recommendation, and you have to kind of go through a lot of steps to get there. It's summarized here in this guideline that says you have to be severely symptomatic with primary severe MR and high or prohibitive surgical risk. And you have to still have a reasonable life expectancy. And that's really what edge-to-edge repair is indicated for currently in the United States and around the rest of the world as compared to surgery, which is for everybody else in that group, because surgical mitral valve repair is an excellent operation. What about on the other side, on the secondary MR side? Well, here we're a little bit more mainstream. We're not sort of way off to the edge of the guidelines, but still, again, there are a number of different criteria you need to go through. But here, there at least there's nothing green with surgery. Everything is in the class 2 recommendation, and transcatheter edge-to-edge mitral valve repair is a 2A recommendation for patients with chronic severe secondary MR related to LV systolic dysfunction who continue to have symptoms despite optimal GDMT, which is very important. And in these patients, as long as the anatomy is reasonable and the valve appears to be treatable, The LV is not too dilated with an end-systolic dimension less than 70. And they don't have bad pulmonary hypertension. These are essentially the inclusion criteria from the COAP trial. Then there's a 2A recommendation for transcatheter edge-to-edge repair. And that's really it. That is the current guidelines summary with respect to management of mitral regurgitation. So we're kind of constrained to these two criteria. Again, a secondary MR with not too dilated of a ventricle, and primary MR who are patients who are at high risk for surgery. So there is a lot of enthusiasm and impetus for seeing if we can safely expand the indications for transcatheter edge-to-edge repair. And there are two trials that have just started up recently which are going to be testing this. One is the REPAIR MR trial, which is a industry-sponsored trial of patients with severe primary MR who are in the moderate risk category. They can get into this trial if they're over the age of 75, no matter what their risk is, or if they're moderate surgical risk, meaning an STS risk score of 2% or greater, or have some specific comorbidities that increase risk. The surgeon has to agree they're a decent candidate for surgery. An eligibility criteria committee has to agree that you have a high likelihood of achieving 1+ MR or less with MitraClip. It's a 1-to-1 randomization to, again, MitraClip or surgical valve repair, about 60 sites, being sponsored by Abbott. And you can see the endpoints here have two. There is a clinical endpoint of all-cause mortality, stroke, rehospitalization, or AKI at 2 years. And then there is a anatomic criteria of having greater than 2+ MR or need for a repeat mitral valve intervention within 2 years. There are a number of secondary endpoints which are presumably there because they are very likely to favor mitral edge-to-edge repair, like discharge to home, length of stay, and then the quality of life of the patients measured by the KCCQ at 2 years. And the follow-up, importantly, will be going on for 10 years to really give us a look at the durability of these two approaches. So that's one study that's going to attempt to see whether we can safely expand the bounds of edge-to-edge repair. The other one is called the primary trial. This is being run through the CTSN, the Cardiac Thoracic Surgical Network in the United States, which is an NIH-funded enterprise. You can see here a very, very large list, but it also includes investigators from Canada and the EU. This is for patients a little bit younger, so the patients they can be 65 years of age or older with 3+ or 4+ primary degenerative mitral regurgitation with an accepted indication for valve repair. Basically, they meet guidelines for valve repair. Interestingly, in this group, they can be any risk. You can even include low-risk patients if they're over the age of 65, randomized to mitral valve repair or transcatheter edge-to-edge. The primary endpoint is at 3 years, all-cause mortality, valve reintervention, hospitalization for heart failure, or development of 3+ or greater MR. And then secondary endpoints is the adequacy of MR correction, quality of life that's being measured by the KCCQ through 5 years, and then follow-up going all the way out again to 10 years. So these two trials are just starting up. So I think, in terms of, getting to the primary endpoints, we're at least 5 years away from these for getting these really important secondary endpoints about durability. 10 years away, so I think I'll be retired by the time these are really usable, but I also think they're very, very critical trials to really help us understand where these therapies fit in. Finally, let's talk about mitral valve replacement, transcatheter mitral valve replacement. Now, this is not currently available in the United States. I don't believe it's currently available in Asia either, but it is available in some countries in Europe with a few devices, mostly one particular device that's a transapical device right now. But there's a lot of research going on. There are a lot of trials and a lot of devices being tested. So one question that may be out there is, do we really need a transcatheter mitral valve replacement? Who are the patients who might potentially benefit? And you can see some of them listed here. Obviously, patients who are high risk for open MVR but aren't good candidates for edge-to-edge repair. Patients with MAC are a very critical group where the surgeons really don't like to operate very much. Maybe patients with endocarditis, again, high surgical risk, and patients who need some form of mitral valve therapy are high risk but are poor candidates for transcatheter edge-to-edge repair. These are the patients from whom we are really drawing the trial populations for TMVR. But this is the technology that is developing very, very slowly. And again, there's a number of different reasons why this may be. Some of them are anatomical reasons, like the size of the annuli, non-calcific annuli, things that have to be dealt with. As a result of this, there are a number of technological compromises like transapical route, high valve profiles that drive the valve into the LVOT and cause obstruction there, low radial force, which means that you may not be able to expand well in the case of a MAC. And so there are a number of challenges that we're facing today. The large bore transeptal, if we're going to be a transeptal, LVOT obstruction, which is really, really critical, and a couple of others. And so what are we doing to try to address these? Well, first of all, there are solutions on the valve side. So there are valves like the Sophia valve, which has a very, very low profile in the LV. And in theory, this will minimize some of the issues with LVOT obstruction. Another approach is the M3 platform, which is Edwards platform that involves a docking system that is placed around the mitral valve itself, pulls the anterior mitral leaflet away from the outflow tract, and then you place a sort of prototypical balloon expandable valve inside of that dock. And a very, very unique system, the 4C Alta valve, which is a device that sits entirely within the left atrium, avoiding any problems of LVOT obstruction. But again, this is a very, very large device taking up the entire left atrium, and right now you have to custom build it for everybody's left atrium. There also are a couple of things that we're doing on the procedural side that aren't the valve, which may, again, are enabling technologies for some of these devices. One is the Lampoon procedure, which is a mitral valve splitting procedure that involves electrocautery, kind of summarized here, but you're basically making a split in the anterior mitral leaflet, which removes some of the problems imposed by the frame of the TAVR valve, imposing the anterior mitral leaflet in the outflow tract. And a very new procedure that's sort of crazy, but I actually participated in one a couple of weeks ago at our center that was led by Jafar Khan, who's really one of the developments of this, just a procedure in which you actually drive a wire through the interventricular septum, electrify that wire after snaring it in the LV cavity, and then pull that back under electrocautery, which makes a myotomy, a semi-surgical myotomy in the LV outflow tract, allowing, again, more passage of blood and minimizing the risk of LVOT obstruction. So what are my predictions for the field at this point in 2023? I think given the complexity of the mitral valve itself and the multiple mechanisms of MR, I think catheter-based approaches for the mitral valve are going to continue to lag approaches to the aortic and realistically the tricuspid valves. Based on what we already know, the unparalleled safety and widespread adoption of transcatheter edge-to-edge repair, this is going to remain the mainstay of therapy, transcatheter therapy for the foreseeable future. And depending on the outcomes of those trials that I suggested, this may become a reasonable alternative for some of the intermediate risk patients in the future. I think TMVR is initially going to be approved and used almost exclusively for MAC, where the surgical outcomes are poor and where the surgeons would be very happy to have some alternative approach than doing a surgical valve replacement. But finally, I think really the panacea of a true catheter-based solution to mitral regurgitation is going to require a multi-pronged approach, probably a toolbox type of approach that involves technology, technique, and putting them all together. And that is probably at least a decade away and really something to look forward to in the future. Thanks very much.
Thank you. Thank you very much, David. Great presentation summary. And next, on the tricuspid side now is Horst. He was on the same plane, so I'm glad he made it too.
Thank you very much. I passed you by at the immigration. So what is coming? Well, devices on the drawing board, in preclinical, in first-in-man, approved, CE mark, FDA approved, available in all specialized hospitals, reimbursed. In one or the other way, all tricuspid valves are currently coming somewhere and somehow. Let's go through the different technologies which people are working on. There's first leaflet and chordae interventions. These are the TEER devices as well as Mitralix. Then we have the annuloplasty devices. Then we have the spacer devices which fill in the gap between the leaflets. Then the heterotopic implantations and the orthotopic valve implantations. We will go through these devices, at least in some of them. So let's start with the leaflet and chordae interventions, the TEER devices. It actually all started, as you know, with the mitral clip in tricuspid position as an off-label use, but the procedure was really terrible. The results were actually pretty good when you see the initial results here, 77% procedural success rate, but from the technology side, it was really difficult, and there was a major change when the special delivery sheath was developed, and now we have the Clip Gen 4 as well as the Pascal device, and more than 10,000 patients have been treated with the TriClip and more than 5,000 patients with the Pascal. And there's another one coming from China, the Dragonfly, which has some detailed advantages compared to the other one. We don't have time to go through these details here. And then we have the Mitral device, which is not really targeting the leaflets. It's just below the leaflets. It's wrapping the chordae, so it's a spiral which is put into the space below the valve, and then it's turned around and you bring the chordae together. This also facilitates adaptation, coaptation of the leaflets. Then we have the annuloplasty devices, and although in surgery, as you know, annuloplasty is a major technique to treat tricuspid regurgitation, on the catheter side, it looks more difficult because many of them already have disappeared, and you can see that only few remained, and people are working on them. Cardioband has CE mark for mitral as well as for tricuspid, but it's currently not available. It's under redesign since 2 or 3 years now. TriPTA is ongoing. It's a right atrial appendage puncture. Then you get pericardial access. A circumferential implant is delivered along the AV groove. Then tension is applied. Right atrial puncture hole is finally closed with an umbrella device. But what you can see here, the first publication came out in 2015. So it's really a long, long way for these new devices. The MIA device, polyanchors and a thermoplastic elastomere. These anchors are placed into the annulus between the posterior septal and anterior posterior commissures, and then subsequently they apply tension, and basically the valve becomes a bicuspid valve at the end. They have done 31 patients now, and they reported reduction in annulus dimensions in TR and improvement in quality of life. Then we have the Da Vinci system. A scaffold is positioned on the annulus. A ring and stakes are attached to the annulus in a single-shot procedure. The ring and the tether cord remain in place. The tether cord is secured below the skin at the subclavian level, stays there for 1 to 3 months, and then the attachment tool is advanced over the cords, tension is applied, and the cords are cut and the implant is locked. This device is currently under redesign, as many others. Tricuspid bridge implantation, Submarian is working on that. A very simple device, and I like the concept. They have done animals and will start first in man soon. So they're basically creating a simple bridge between the anterior and the posterior commissure to minimize the diameter of the annulus. Then we have the spacers. Again, one of them is not available anymore. The former concept has been stopped. Croy valve is ongoing. We did first in man in a temporary implant with this technology. You have an anchor system in the superior vena cava, and then a bridge which connects to the spacer, which has a valve inside. So it's a combination of spacer and valve implantation. Then we have the Coramasa. We also did FIMIT with that one. It's an anchor in the right atrium. And then you have the spacer between the leaflets, and there is a flexible connection between the anchor and the spacer. So it kind of finds its place by itself. And then we have, the heterotopic valve implantations. It started all with Sapien in the IVC. This is, I think, not performed anymore, but there's the trick valve. You can see the concept is a valve in the superior vena cava, another valve in the inferior vena cava, and then you have basically ventricularization of the right atrium. So the right atrium now belongs to the right ventricle. And you can see the hemodynamic effect. When you inject in the right atrium, you see there's no flow going to the IVC and SVC. And you can see a high pressure in the right atrium because it becomes part of the right ventricle. But the pressure in the superior vena cava and the inferior vena cava is low due to these two valves. Same concept is the Tricento device, and there's also another one, the Trillium device, which is going from the SVC to the IVC and then has these kind of openings in the endograft which work like a valve. And finally, the orthopic valve implantation, Navigate. We did the Navigate first in man trial. This is not available anymore. At least the company is inactive. And then there's a Trisoldi valve, a single dome-shaped leaflet. It's a different valve design which may have some hemodynamic advantages. It's a transjugular approach, 31 French delivery system. It anchors on the leaflets. It can be repositioned and retrieved, and first in man was done in 2021. And then the Evoque from Edwards, access transfemoral sheath is down to 28 now, anchors on annulus, leaflets, and cords, and comes in valve sizes up to 52 millimeters. And then the Chinese Yenska Lux valve, transjugular access. This is special because it anchors on the leaflets and on the interventricular septum. There's a kind of a stabilizer here which is attached to the interventricular septum, and it anchors there. It comes in valve sizes up to 70 millimeter, which is good because that's limitation from many other valves that you have not valves large enough to cover the range of diameters what you see in these patients. And then the Tricar Topaz, transfemoral access, 29 French, currently for tricuspid annually up to 45, porcine pericardium, 3 leaflet valve, 2 stent design. And then we have the cardio valve, another one from China, which is now actually manufactured in China. You can see it's inserted into the valve. It grabs the leaflets, pulled back, then the second part of the device is pushed out. It has a cuff to prevent paravalvular leak between these two device parts. It covers up to 55 millimeter annulus diameter. And then the Vida, another very different concept, transfemoral access, 24/8 French sheath. It's a side delivery, which means that the delivery system does not really enter the right ventricle, and it's repositionable and retrievable, and valve sizes up to 70 millimeters. And I'll just move a little forward. You can see that the device, the delivery system, is outside of the right ventricle. It comes from the side and is deployed in this way. So tricuspid interventions have evolved to a routine procedure. Currently, the vast majority of patients are treated with TriClap. Other edge-to-edge techniques like Pascal, Dragonfly, and others will catch up. Several other non-edge-to-edge techniques for transcatheter tricuspid valve repair are in an early stage. Several percutaneous tricuspid valves are in preclinical and clinical trials, and extracardiac valve implantation is an option for patients with anatomy not suitable for direct repair or valve implantation. Thank you very much for your attention.
Thank you very much, Horst. And I think we move on to the cases now. Is that correct, Ellen? You have the first case, mitral clip, with Dr. Kim from Severance.
Yeah, thank you. It's my great pleasure to have opportunity to give a presentation in this meeting. I prepared 2 interesting cases with the mitral clip. Here's my disclosure. A mitral clip system is recently introduced in Korea in 2020, unfortunately, and right now mitral clip G4 system is available in Korea. So there is some limitation, increased number of cases because it's not covered by insurance. So patients should pay all cost for this procedure, which is a very costly procedure. So I would like share 2 cases. First case is 66 years male. He experienced ischemic cardiomyopathy and dilated cardiomyopathy and half left, ejection fraction 16%. He already treated with optimal medical therapy and CLTD, and he has also CKD. So in the echocardiographic shows severe mitral regurgitation, as you can see here, which is not meet co-op criteria. So what is the best option for this patient, LVAD or heart transplantation or bridging therapy with a TEER and surgical repair or replacement? We decided try to perform the TEER procedure first, but as you can see here, there is a large gap because the renal function was deteriorated during the admission and volume control was not efficient with the maximal dose diuretics. So we decided to postpone the TEER procedure. And then, coaptation gap significantly decreased over the bigger volume control with the continuous renal replacement therapy, as you can see here. There is some coaptation was done. So we tried to perform the again for the TEER procedure in this case. So the patient condition was not so good. We prepare all device with the XC system and finish the procedure within 1 hour for this case. So after deployment to XT system, as you can see here, ML was significantly decreased. So we successfully deployed the device, and then after 1 day after transthoracic echocardiography shows TL was trivial with MDPG was 1.0 millimeter mercury. So we did successfully implanted this device for this patient. Second case is 84 years female, complained of dyspnea and orthopnea, and she has also persistent atrial fibrillations in CKD. And huge chest X-ray shows a huge cardiomegaly and atrial fibrillation. And transthoracic echocardiography shows severe mitral regurgitation, as you can see here, and tethering of PML and overriding AML, which is a characteristic feature of the atrial functional MR. In TE shows a similar finding, but there's some concern about some thickening of the mitral valve anterior and posterior mitral leaflet. But in the anatomical criteria was met, MBA was a 5.0, and coaptation length, and coaptation depth, and PML length is enough for the procedure. So we at first choose a XTW system, but as you can see, this transthoracic echocardiographic finding, there is some residual MR, and MDPG was 2 to 3 millimeter mercury. So we try to do another clip with the XC system, as you can see here, shows a significant decrease. But after deploy the device, as you can see here, there's something wrong here. There's a SLDA was occurred in second clip with the XC system. So posterior leaflet was detached in the second clip. So how to manage SLDA in this situation? Apply third clip to stabilize the second clip, or observation, because the clip was well attached with AML and MR was significant decrease, and surgical conversion. We choose a second option. So 1 day after we did transthoracic echocardiography, shows a significant decrease in MR and MDPG 3.4 millimeter mercury. But patient complained of light inguinal area pain and agree with dyspnea, as you can see here. In the chest X-ray, shows second clip was disappeared. And we tried to find out the location of the embolized device. So embolized clip was found in the right common iliac artery, as you can see here. So which is confirmed in the CT scan. So in this situation, we should reduction of the MR as well as a remove of the embolized device. So we tried to perform TEER again to check the possibility of redo TEER in this procedure after 30 days after the procedure. So as you can see here, increase the MR. Then we put an anti-W system, and then we successfully decrease the MR with this procedure. Then we puncture the right femoral artery with a 60 French check flow introduce sheath. But in this case, we already did a pre-close strategy with a per-close system. Then we tried to snare this device at first 10 millimeter, but there's some failure to this distant bifurcation site, which usually go through the internal iliac artery. So we put another snare, 15 millimeter, with the first snare, and then angle adjustment was made easier with the double snare technique and past the bifurcation site. But the other issue is to snare the mitral clip could not enter to the 16 French sheath. So we tried several times. Finally, we beveling the device, remove the device sheath and beveling the distal tip, and then introduce the sheath. Then finally, we remove the device, as you can see this slide. So After remove the sheath with a percutaneous system percutaneously, and then angiographic shows any complication. So here is remove the device, as you can see here. So this report was recently published in a European Heart Journal case report. Thank you for your attention.
Thank you very much, Dr. Kim. And next is Dr. Grube from Kurashiki, talking about tricuspid valve intervention.
Thank you, Eberhard. I presented at the tricuspid repair procedure today. But I'm not a master. I'm just training because in Japan, just tricuspid trial was finished. So also I cannot show my own case due to the trial limitation. So I asked the agent colleagues to share his case. So this is a trial. This trial was presented this year. So 350 patients randomized to TAVR procedure and optimal medical therapy 1-to-1. And as you can see, the TAVR procedure significantly reduced the TAVR with 87% of the moderator less, and also improves the quality of life. This is a TriClip G4 device, which is used in the trial. Different from the mitral clip device, there is a SL knob in the guide catheter, and there is no M knob, and there is a flex knob in the clip delivery system. Of course, we can use all 4 types of the clip in this device. So this is a case, 85 years old gentleman who had a leg edema and a dyspnea due to a severe TR, and her team decided to perform a TR procedure with a TriClip device. The past history is here, the atrial fibrillation and chronic kidney disease. You can see the TT findings. The LV function is normal, and there is a massive TR with 0.77 over AROA. This is a TE findings. Here is a 3D TE. You can see aortic valve here. So this is the anterior leaflet, this is a posterior leaflet, and this is a septal leaflet. As you can see, the posterior leaflet is separated and 2 leaflets. This is 3D color image. So you can see the white TR from the anterior side from the posterior side. This is a transgastric image, which is the most important view in the TriClip procedure. As you can see, this anterior leaflet and the septal leaflet. This image also confirms the 2 posterior leaflets. And also you can see the white tear jet from the anterior side to the posterior side. This is the RV info and outfield image, which is the grasping view of the TriClip procedure. You can see the papillary muscle here. So this is the anterior side. This is the posterior side. So this is a central anterior septal leaflet. You can see a small gap here and a large tear jet. So this is the central posterior septal leaflet. You can see also the small gap here, and there's the tear. Also, you can see the tear jet here. So how to clip the tricuspid valve in the TriClip device? So generally, we can grasp the septal leaflet and the lateral leaflet. So lateral leaflet includes the anterior posterior leaflet. But as you can see, there is a rich cord in the posterior commissure side. So we don't want to put the clip in the mid to the commissure posterior septum. So our strategy is that put the first XTW in the anterior septal, and next the second XTW in the posterior septal as needed. This is a procedure. We don't need to puncture the transseptal. So we directly inserted the guide catheter and the clip delivery system. So also, of course, we have to check the trajectory and orientation. So when we push a guide catheter, the clip going to the posterior and anterior. And if you use the flex knob, so you can adjust the trajectory. And when you turn the guide cutter to the clockwise or counterclockwise, so the clip going to the septal and the lateral side. And the SL knob was used for the adjustment of the septal hugger, and plus minus knob is used for the height adjustment. So when you adjust the trajectory, so you have to insert the XTW clip to the RV, in the RV. And orientation should be checked in the transgastric image because the 3DT is not so good image after the clip insertion. So in this case, the leaflet graspings are not so difficult. You can see enough leaflet tissue on the both arms and put the gripper down and closing clip. So after closing clip, you can see the MR reduces mild. So CT confirms the MR reduction, so we release the clip. So after releasing the clip, there is no tear around the clip, and the tiny tear, the posterior commissure. So we finish the procedure. Actually, this is a very straightforward case, but the tricuspid valve anatomy is very complex, and this complex anatomy will affect the clinical outcomes. In this study, the 4 leaflets and the large coaptation gap affects is strongly associated with the residual tear. So how about this anatomy? So this, you can see the torrential tear, there is a large gap more than 7 millimeter, and septal leaflet were divided 2 leaflets. And also in the RV info outfield image, you can see the massive tear from the anterior side and also the posterior side. So in this case, so same as the previous case, we put the XTW for the central anterior septal side, and try to put the second XTW for the central posterior septal side. But as you can see, the significant residual interclip tear from the between the 2 clips. I think it's due to the indentation of the 2 septal leaflets. But we decided to move the clip to the more anterior side and try to grasp the anterior and this is very short septum. It's a very tough grasping, but finally we can do it using the control gripper actuation system. And after closing the clip, you can see the MTR reduces the moderate. I think that this kind of the anatomy is very challenging for the edge-to-edge repair. So we need the further intervention device for the tricuspid valve. So in summary, the TriClip procedure is generally safe and effective for the tear reduction. However, the procedure became challenging in the complex anatomies, including the large coaptation gap, 2 septal leaflets, septal leaflet tethering, and poor image quality. Thank you for your attention.
Thank you very much for this great summary of the clip in tricuspid. Any comments or any questions from the panel?
Yeah. Yes. Regarding the Lapun procedure, we found that tip to base would be easier instead of punctured anterior leaflet and lacerated. So maybe a tip to base approach would be safer, I would say.
Yeah.
Comments? And tricuspid interventions are difficult. Have you tried to use ICE, 4D ICE, to do the imaging instead of TEE?
No, thank you for comments. So no, because 4D ICE is not available in Japan now. So I think that the TE guidance is still standard for the tricuspid procedure.
Horst, on your summary of the new devices, I remember a slide from you where you had the 25 or 30 mitrals, and you said, you know, it's probably a good indication none of one really works well. Do you have any idea of the ones that you presented? Will they all be successful, or do you think it's just another way of looking at replacement in the tricuspid area with more or less success?
I mean, I think the history will be the same as in mitral, so most of these devices will not make it. But please don't ask me which one will make it.
I want to just add that, I mean, I think the tricuspid valve replacement is not benign. I think, you know, especially the anticoagulation issues, which are, many of these patients have liver failure and they're challenging. And so that's why I think there still is so much attraction of the edge-to-edge repair, which is much more, you know, it doesn't put such a large device in the valve. I don't know what your thoughts are, Horst, about that.
So,
I fully agree. I mean, ideally, we would like to have a repair first before we implant a new valve. And ideally, this repair should not hinder us to implant the valve. So that's the problem with clips. That's also the problem with some of the other devices like spacers. If the spacer's in place, then you cannot implant the valve anymore. So actually, I think annuloplasty devices is what we need. And unfortunately, they all fail.
yeah, David, while you're there and close to the mic, would you be, as a study man, the somewhat sobering triluminate, would you kind of comment on that?
Yeah, it's definitely been very interesting, and it was somewhat sobering because I think we were all hopeful that there would be not just a quality of life improvement, but you weren't that hopeful?
No.
Well, those of us the optimists among us were hopeful that we would see also some clinical change. And I think that really is the question, is why are we not seeing that when we see a pretty meaningful quality of life difference? That 12-point difference is quite meaningful. It's very similar to what we saw in COAPT, which was about a 15-point difference at a year. And so, you know, it's an interesting question is, you know, why are we not seeing a reduction in hospitalizations? These patients they were very selected, and in some ways they were selected, you know, we thought we were selecting the patients who were best candidates, so they really just had TR, but it may turn out that that's not the right group to select. And I think we have so much to learn here, and I hope that we will, you know, from the other two trials that are going on comparing it to medical therapy, learn enough that we at least have a solid foundation for the field, because, you know, once we have a couple of approved devices, everything else is going to be tested against those. And so you want those to be a very solid foundation from which to build. And I think that, you know, again, it would be nice if we saw at least some hints of changes in the mortality or at least the hospitalization endpoints.
Do you think that quality of life criteria is sufficient for approval?
Don't ask me. I mean, I think that really is the big question, and the companies are certainly asking it. I mean, I will tell you that my own group is doing a lot of work actually with the companies and with the FDA to try to really understand how important those quality of life changes are, whether they are, you know, meaningful, whether that is measuring the right endpoints. We hope to be presenting some of that stuff at TCT this coming year. So there's a lot of interest at a minimum. I think it's approvable as long as we're sure it's real. I mean, I think the patients, you know, most of these patients come to us to feel better. That's their goal. And so we should be able to approve things as long as we're certain that that's what's really happening. I would think they're approvable.
So David, when you're up there, so you have the slide showing, you know, the patient population that would need TMVR, and obviously from the clinical side, the patient population that the most difficult to treat, and the answer usually is that we can help you is the MAC patient. But it seems like from the industry standpoint, they want to grab the whole market. It's really, you know, the MAC is always kind of a side thing versus that's the main sort of the need. What do you think? I mean, if we do a MAC trial only, is that too small population, or?
I mean, I think as I said, I think that's where if you look in Europe, in Germany, where, you know, transcatheter, you know, at least, you know, the Tendyne valve is approved and being used, that's who it's being used in. And the Germans lead, and we should look at them and see what they're doing, because that's where it's going to, I think, where it's going to start in the United States as well. We know from the trials that are going on in the United States, originally they were designed as randomized trials against surgery, but they're enrolling much better in the parallel MAC registries. And so the challenge with MAC is that these patients tend to have small LVs, small LV outflow tracts, and therefore they have all these problems with obstruction. And so I think, if we can just perfect some of these other techniques, like the sesame technique that I showed you, or the lampoon technique, that opens up a lot more opportunities, and those are not being allowed in the trials. So I really think, it would be nice if we had transcatheter mitral valves that were like TAVR, that one valve worked in all these different anatomies, but I think that's a really far reach, and I think we should be happy with MAC for now, a group that we can help that don't have good treatments right now. That's my personal view.
Okay.
Yeah, you wrap up.
All right. No, sorry, question? You have a question?
No.
Oh, okay. Oh, okay, so I think because of time, we can wrap up this session. Thank you very much for all the presenters, as well as the very sort of lively discussions. And let's turn it over to the next group in the evolution of imaging and physiology.
Thank you.